Okay, great. Well, good evening, everybody. Welcome to our monthly episode of Cerebrovascular and Skull-Based Surgery Symposium. This is session 45 on today, July 21. We have a fantastic panel who I will introduce shortly. And today the topic is surgery for brainstem cavernoma. And of course, I'm joined by my co-directors in general, Carolina Benjamin, Mike Ivan, Bobby Stark, and our two panelists, Eva Wu, our PG3, and Matthew Sun, our fellow. Here is Matthew, who just started fellowship in our program, and this will be his first time to join us on these monthly sessions, and Eva has already done it several times, and they will each present a case at the end of the presentations. Again, many thanks to the team that makes this happen, particularly Ignacio, who is running this webinar. Mark your calendars for the future sessions. They're not always on a third Thursday because of other meetings. So the next one is August 11, then September 15, and then October 13. And I will show you the flyers. This is next month, petroclival meningiomas with Velutini, Agazi, and Liu. In September will be treatment controversies in AVM with Dedashti, Steinberg, and Adam Arthur. And in October will be surgical management of acoustic neuromas with Astagiri, Samez, and Bashkaya. And we'll announce subsequent ones later. As of tonight, very special treat to have three people who are really quite passionate about the brainstem in general, particularly cavernomas. Mike Lawton, who certainly needs no introduction, who is of course CEO and Prof of Neurosurgery at the BNI. Mike and I were under the umbrella of Bob Spetzler back in the early 90s, and of course we've remained friends all these years. Mike is going to talk about the value of taxonomy, as he has done beautifully with his other topics on aneurysms and AVMs and bypasses, and now he turns his attention to brainstem cavernomas. Peter Vashkozy, the chair at Charité Hospital in Berlin, who manages to stay awake right now to be with us like Oliver. It's past 11. And Peter, one of the smartest people I've certainly met in my life, is going to talk about the value of TMS in pre-op imaging. And he has quite a fascinating way of looking at things. He's also interested in spine and cervical spondylosis and tries to link those issues with the brain, and he might say a word about that. And last but not least, Oliver Bozinov, who is chief of clinic at Kent Hospital St. Gallen in Switzerland. Oliver has had for several years a wonderful symposium on brainstem lesions in January of every year. And he loves the topic and of course has published on this extensively. And he's going to talk about the value of intraoperative monitoring in these surgeries. So without further ado, I am going to ask Mike Lawton to share his slide, unmute his microphone, and talk to us about taxonomy. I'm asking everybody to speak for about 20 minutes to leave plenty of time for audience participation. And by the way, the audience, please put your questions in the Q&A box throughout the presentations. We will address them at the end. Thanks. Mike, all yours.
Okay, thank you, Jacques. Can you see my title slide?
Yes.
Perfect. Okay. Well, first of all, thank you for the opportunity to speak, Jacques and team, and my congratulations to you all for continuing this webinar series well past the pandemic, and it's been a real success, so nice work. So as Jacques said, I've turned my attention to the next on the list of sevens, and that's the cavernomas. And The title of this talk is Demystifying Brainstem Cavernous Malformations. This is my profile, over 1,000 of these things. The brainstem numbers are up about 330 or so now. And this talk is really a distillation of all of this experience that has come through all of these cases. As some of you may have noticed, the efforts that I and my team have been doing are appearing in the Journal of Neurosurgery as the 7 Cavernomas collection, which is a series of articles. We've gotten 8 either printed or in press, and there are another 8 that are in process. So this is coming out, and you can see some of the details of what I'm going to share with you in the papers. But I think the key for demystifying cavernous malformations, particularly in the brainstem, in my view, is this idea of a taxonomy that we can all understand, that we can all embrace, and it will help us make the right decisions. It is intended to help identify the right surgical approach to the lesion so that you optimize your outcomes, you make good decision making, and there are a lot of unintended advantages as well, which I'll touch on. So the taxonomy, I just want to begin by introducing this to you. And I would say that what I decided to do for this was to pool my data with Dr. Spetzler, who had over 400 or so of these. And so together we have a pretty robust set of these lesions. And because he trained me, our style has been similar. So I think it represents a pretty consistent pattern between 2 surgeons, and many of these were done at the same institution, in fact. And so when you put this together, this is the taxonomy. What you'll see is, like all of my taxonomies, I think of them in terms of types and subtypes. And the types, at least for the brainstem, are midbrain, pons, and medulla. And the subtypes are these various ones that you see. There are 5 midbrain subtypes, there are 6 pontine subtypes, and there are 5 medullary subtypes. And if we look at these in detail, these are all based, as I did with the AVMs, on the surface of the brain that the malformation is presenting to. And so it's either anterior, anterolateral or lateral, posterior or posterolateral. And you can see in this illustration from Peter Lawrence how the boundary lines are defined anatomically very specifically. And you can see, for example, the interpeduncular and the peduncular separate very nicely by the inner edge of the cerebral peduncle. In the pons, you can see that line, Roton's transolivary line that he uses for the definition of arterial segments, defines the borders between the basilar and the peritrigeminal, and so forth. These are all very anatomical based, and this is a kind of a representation of the surface that defines the lesion. So these are just an overview, and this is now a different perspective, looking at the side or the posterolateral view or the pure posterior view for these other subtypes that are around the back. And you can see the quadrigeminal and tegmental for the midbrain. You can see inferior peduncular and rhomboid for the pons. And then below the stria medullaris in the medulla, you can see trigonal, gracile, and cuneate lesions. So I think the starting point is really just memorizing these 16 subtypes. And then, well, this is just another way to think about the territories. Those previous illustrations were the surface anatomy for these. But if you look at the kind of the cross-sectional anatomy, you can see how these nicely partition these various levels of the brainstem into these subtypes, in teal for the interpeduncular, red for the peduncular, orange for the tegmental, and so forth. As we go on down to the pons, you see the same things for the basilar subtype, the peritrigeminal subtype in red, the middle peduncular in orange, the inferior peduncular in green. In blue, we have the rhomboidal, and in yellow, sort of ghosted in, this is the supraolivary, which we approach from below. And then moving on to the medulla, you can see the various ones here as well. You've got your pyramidal ones in the front, your olivary over here, number 2. These are the cuneates, 3 in orange. The graciles are in 4, and the trigonals in 5. So again, learning just the terminology, those 16 terms is the beginning point for the taxonomy. And now I just want to show you how this adds value to your decision making. So once you identify a lesion from your MR imaging and you label it as a particular subtype, then that will take you to the approach. And so this is kind of based on the experience that I referenced. This is how, and Dr. Spetzler and my experience, this is how we manage these. The different approaches for the lesions are laid out here, and each one of the subtypes has its own unique approach. So it's important that you, if you properly categorize the lesion by the taxonomy, it will tell you the recommended and probably best surgical approach. So I'll walk you through these, and we'll start with the midbrain. For the midbrain, the interpeduncular lesion you can see is approached with an orbitozygomatic craniotomy, and it's a transsylvial interpeduncular approach. So looking at the central image here, the anatomy is just like you would approach a basilar apex aneurysm, which you do your dissection down to the P1-2 junction, work your way medially. You're working in the carotid ocular motor triangle, and you're accessing the malformation in that interpeduncular fossa between the third nerves. And you can see in this panels to the right, you'll see your safe entry zones. In the dashed lines, you'll see the triangle that we use for the access, which is really important. We'll talk about the triangle concept for these lesions later, but the ocular motor, the carotid ocular motor is the triangular space. And you can also see the tracts that, or structures that are of critical importance ghosted in here. For the pedunculars, it's very similar, except that you're moving into a different triangle. Instead of the carotid ocular motor triangle, the working triangle is over here. It's the ocular motor tentorial triangle. And you can see how it's really below the P2. Usually when I access these lesions, I tend to go below the P2 and above the S2. There are some where you might go above the P2, but primarily it's in this space here, just above the pontomesencephalic sulcus here. And this is the working space, and it differs from the prior one, even though the craniotomy is the same. As we go around to the lateral lesions, this is the tegmental lesion. It's on the posterolateral aspect of the midbrain, just behind the crus of the cerebral peduncle. And you can see the lesion here. It's defined by this lateral mesencephalic sulcus. That's your safe entry zone. And the triangles here are either the supratrochlear triangle or the infratrochlear triangle, depending upon how high or low the lesion sits on that tegmental surface. As we go now to the quadrigeminal subtype, you can see this beautiful picture of the torqueular craniotomy, the supracerebellar infratentorial approach, and the use of the infragalenic triangle, which is the space defined by basal vein of Rosenthal and the precentral cerebellar vein right here. And when you get into that little angle there, this is where the colliculi come into view, and you can access your malformation here. I do these in the sitting position. It allows gravity to open this space up beautifully. And over here, you can see that if the lesion's not on the cortical or the brainstem surface, you can use either the supracollicular, infracollicular, or intercollicular safe entry zones for these, taking care not to go too deep that you disturb the collicular nuclei or the fourth nerve at the bottom. Now, the last for the midbrain is the periaqueductal, and this one is for those that sit at the top of the midbrain, sort of at the funnel of the aqueduct, and these are approached through a bifrontal craniotomy, a transcallosal transchoroidal fissure approach, opening up the roof of the third and getting all the way back, as you can see in this illustration here, to that funnel of the aqueduct, where you're going behind the massa intermedia and accessing these from above. So this is as far or as deep as you can take that interhemispheric approach through the choroidal fissure, but it takes you very nicely to the top of the midbrain. Now, as we go down to the pons, you can see, again, our 6 different subtypes here, each with their own unique approach. And I'll just walk you through these as well. For the basilar subtypes, the main one that we rely on is the quasi approach, a transsylvian anterior transpetrous approach. And it takes you nicely, as this illustration shows you, under 5, over 7 and 8, and right to that anterior portion of the pons just alongside the basilar trunk. It works beautifully for this space. If it's higher, we did one last week, we went trans-sylvian and used almost like a transcavernous approach, dropping down into that upper belly of the pond. So there is a little bit of variability for these depending upon the location of the lesion, high or low. This is some of the details of the anatomy showing the working space in that infratrigeminal triangle here. And this is the corticospinal tract, which is the thing of concern here. As we go around to the peritrigeminal, we change now to a retrosigmoid approach. And I like the extended because it gives you that extra working space if you skeletonize the sigmoid in the front. But this is all retrosigmoid, it's not presigmoid. Our working triangles can be either supratrigeminal, infratrigeminal, or in the glossopharyngeocochlear triangle. And you can see those three triangles illustrated here in these different views. Our safe entry zones are either above the shoulder of the trigeminal nerve in the supratrigeminal safe entry, or below the axilla of the nerve in the infratrigeminal triangles. And you can see this is really nice for these lesions that present on that surface. Now, contrast that with the middle pedunculars. These are actually in the lateral pons. And in order to reach the lateral pons, you have to go through the middle cerebellar peduncle. And so the crania, again, is the same, extended retrosigmoid, but the approach differs. It's a transmiddle cerebellar peduncle or trans-MCP approach. And the key for that is to open this, what we call the interlobular triangle, which is the space between the superior and inferior semilunar lobules of the cerebellum in this petrosal fissure, dropping the flocculus, getting all the way out into this lateral space of the peduncle, and then going through that safe entry zone through the MCP to hit the lesion. Now going around to the back, we've got the inferior peduncular, which is really a suboccipital telovelar approach with the intent to get to this point here. It's in the lateral recess above the choroid plexus. So just as the ICP or the inferior cerebellar peduncle is curving into the cerebellum from below. These are where these lesions sit. The safe entry zones are the area acoustica, and the telovelar approach is really the taking down of that inferior medullary velum, opening up this subtonsillar triangle. We call it the subtonsillar triangle because you're really using the midline and the tonsil as your boundaries. You're lifting the tonsil to get lateral, and that subtonsillar triangle is what defines the space. You have to elevate the tonsil to get to that small little window. Now for these, the rhomboidals, these are right on the floor of the fourth ventricle. These are, I think, fairly common to most, but these work through the vallecular triangle. It's the suboccipital craniotomy as the prior example. It's a transventricular approach. The vallecular triangle we define as the space between the two tonsils. It's a potential space, but when you spread the tonsils to either side, you open up the vallecula and you open up this triangular window to get all the way above the stria medullaris up into this rhomboidal portion of the floor. The key landmarks here are the facial colliculus and that looping course of the facial nerve, as well as the sixth nerve nucleus below. And lastly is the supraolivary subtype. So for the supraolivary, you can see it sits right above the olive. The olive is here in the medulla, and just above that is where the underbelly of the pons overhangs the medulla. And by working into that space, it's in the vagoaccessory triangle, which we know very well from pica aneurysms. We get into that space and we can reach it from below. Our safe entry zone is in the sulcus. You can see it with this green line here. And here you can see a real nice depiction of the vagoaccessory triangle, and it's actually working in the suprahypoglossal portion of that vagoaccessory triangle. Now onto the medulla, we've got 5 subtypes here and 5 approaches. Some of these approaches I've already covered. Here, for example, for the pyramidal lesions, here you're trying to get around to the front of the medulla as best you can. So it's a far lateral, but you're using the pre-medullary cistern, not just your usual through the nerves into the lateral medullary cistern. You got to get pre-medullary, which means pushing yourself into what we call the junctional triangle, that space between the vertebral arteries that underlie the vertebrobasilar junction. And that will take you to these lesions in the way front along the pyramids. For the more traditional one that's in the olive, these olivary subtypes are just a standard far lateral, working in the vagoaccessory triangle, opening up that space. You're not deep to the hypoglossal nerve rootlets, so it's really not technically a super or infrahypoglossal, but just into that vagoaccessory space, and you can access it directly. As we go laterally, the cuneate lesions are like the inferior pedunculars in that space that's exposed with the T lobular, but you'll see here it's below the lateral recess. It's actually in the cuneate tubercle below that foramen of Luschka in this space here. And that one is a lot more accessible because it's not as high. The graciles are beautiful. They're much lower. They're usually right at the obex. And in this space here between the midline and this intermediate sulcus here, and you can access these typically through just a transcisterna magna approach of the suboccipital exposure. And then the trigonals, these are the ones that are in the floor of the fourth ventricle, but below the stria medullaris in the medullary portion of the floor. And the key things to know are the vagal trigone, the hypoglossal trigone, area postrema, and staying as protective of those structures as you can. So that's a quick run through of the approaches. And you can see how if you identify the right subtype using taxonomy, it will tell you exactly the approach. So all of this confusion about, what approach do I pick for this? If you just focus on defining the lesion subtype with the taxonomy, it will dictate your approach. Now, a brief comment about triangles. This is an analogy here. When you shoot a gun, you've got a rear sight, a front sight, and you're lining up the barrel of the gun using the two sights so that they merge together. And the same is true in this concept, this triangle concept of surgery. It's not enough to know the craniotomy and approach. It would be like just having one sight and the gun barrel, which is your craniotomy and your approach. You need the triangle to be that extra sight that really improves the accuracy of your approach. And that's how you hit your target here, the cavernous malformation. So we've developed this system of brainstem triangles. There are 14 of them. They're illustrated in this. I've gone through many of these already. Some of these are known and they're not our original contribution, but others are. And I mentioned some of those, and you can see for yourself how these triangles are what really refine the trajectory as you go deeper towards the brainstem. These are the triangles. Midbrain, pons, and medulla each have their own set of 5 or 4 in the medulla, but you can see how useful they are. And this table just kind of brings it together to show you how, if you have the type subtype, it will dictate the approach, and the triangle will again help line up the gun sight so that you hit your target. Now, this is the sort of an overview of that triangle concept. And this is a nice graphic that just shows you that if you define your lesion with the taxonomy and you get to the right craniotomy or approach, there still is the adjunct of the triangle that further separates those bands into exactly where you're going to get to the lesion. So it really is a 3-part analysis: craniotomy, approach, and triangle. And that's the mindset as you do your dissection intraoperatively. These are safe entry zones. I'm low on time, so I'm not going to talk much about this other than to say we've covered a lot of these, and if they're not on the surface, if the lesion's not on the surface, you have to be ready to know your entry zone and use it. The arteries are also very useful. We developed these with Al Roten, these alphanumerics really intended for our bypass nomenclature. But what we found is that the arteries are very useful wayfinders in your dissection pathway. Each of the subtypes has its own unique arterial target, so that if you use the arteries to take you along your trail to get to the target, the artery turns out to be a very useful guide, and that you can actually use the segments as a dissection code. These are just summaries that will be coming out in the collection that you can study, but each of these subtypes has its own unique pathway that you can use the arteries for. And this is just another depiction of how, once you know the subtype and you know the arterial segment that acts as an address to get to that particular surface, you can then follow the arteries along these trails to get you there. And these, again, each subtype has a fairly typical and fairly unique pathway that gets you along that course and to the target. So I'm going to finish with a metaphor. I know my good friend Jacques loves metaphors, so hopefully he'll appreciate this one. The metaphor for 7 cavernomas is maps. And you can see from this talk how by defining types and subtypes, these are really your countries and states on the map. And these other things like the craniotomy approach and triangle, these are your trailheads, your trails and your waypoints along the way that get you from your beginning to your destination. You get certain cues from the rivers that you cross in the wild, and those are your arterial addresses. And the destination obviously is the Cavernoma. So this picture that I've been showing throughout the talk is really one of our artists' depiction of all of this information compiled into this one heuristic that brings together the approaches and the arrows, the craniotomies and the hexagons, the different arterial landmarks, the safe entry zones. And you can see that like a map, if you think about this journey to the brainstem as a trip through the wilderness, just putting all these different wayfinding clues together is really the way that you can find your way through the brain and to your target. So it's a lot in 20 minutes, but just to conclude, I think this 7 Cavernomas framework and this taxonomy is useful. I have found it useful in teaching it to the residents here. I think they would agree. What I haven't talked about is that the subtypes also define clinical syndromes, these constellations of signs and symptoms that are unique for each of those 16 brainstem syndromes. And so not only does it help you define your surgical plan, but it also helps you make your diagnosis at the bedside. And that is always important. But the bottom line is if we make the right decisions in putting together the surgical plan, the patients benefit and we can improve patient outcomes. So with that, I will stop and encourage you to check out some of these papers as they release in JNS.
Mike, this is terrific, of course, as expected. Not only, of course, the thinking that you've been doing about all these things, but those illustrations are spectacular with Peter, with Lawrence, and the others that have helped you over the years and makes it so clear. By the way, again, audience members, please put your questions. We'll address the questions at the end, put them in the Q&A box, and we'll come back to, I'm sure there'll be many questions. Peter, why don't we go to you now? You're muted.
Okay. Spine talk. Good. So Jacques, thanks again for, or thank you for inviting me to this webinar again. I think I agree with Michael that this effort is unmet, that you are continuing this. I was a little bit shocked that you mentioned that you were under the wings of Robert Spetzler in the early 90s. That means, that gives me an idea how old you are, in fact, because I cannot see it on you, on your face. You're young as always, but beginning of 90s is quite a while. Good. So you invited me to talk about improved diagnostics and preoperative planning for brainstem cavernomas. And I think we have heard an excellent talk that is really focusing on the anatomical landmarks and on the function as it's represented under physiological conditions. But I think it makes sense to think about how function might shift if there is a space occupying lesion in the brainstem, even, or like a cavernoma that has bled and that has shifted around things inside the brainstem. These are my disclosures. I should mention that the technique that I'm going to mention is from a company where I'm acting as a speaker once in a while, so this might be important for the disclosure. But let's get into the brainstem. So we've just heard how complex the brainstem is. We have many functions. We have nuclei. We have tracts that are very condensed in a small area, in a small space, and it's a complex three-dimensional organ. And it comes without saying that surgeries within the brainstem are quite risky. There is a significant risk of immediate postoperative neurological deficits or worsening of pre-existing deficits. And they might even be permanent in up to 1/3 of the patients, as described in the literature. And this is why it would make sense, apart from the anatomical considerations, to also think about whether we can localize function and the relationship of the pathology with this function or with the tract by improved diagnostic techniques like mapping and non-invasive mapping before we go into the surgery. And this might dictate, or this might change the approach. So what could be the value of tractography of the corticospinal tract? So the content of the brainstem is certainly not only motor. There is a motor tracts for the leg, for the arm. There are the bulbar for the face, but certainly there are other functions. But I think many of the complications that we see are primarily either deficits in the face or deficits in the extremities. And this is why it makes at least sense to start thinking about motor. This was the reason why Helmut Bertalanffy, certainly one of the pioneers in surgery of cavernomas within the brainstem, started to think about the use of advanced imaging. And he was thinking about DTI with the classical deterministic algorithm, which gives you a way of imaging tracts or showing tracts that are not always reflecting the reality. It's a modeling, and in the last 2 years we have learned what modeling can predict and what not. Here the modeling is also was quite insensitive or unspecific, as the group has shown, and the negative and the positive predictive value was so bad or dissatisfying that the group concluded that DTI might not be of value in planning the surgeries and in predicting outcome. This is another study that has shown the controversy. So this was a randomized clinical trial where the group has randomized patients either to control or to, again, DTI performed in the classical way. And here they were able to show that the risk profile was dramatically reduced when they were using advanced imaging like DTI, which would change their approach and maybe change the decision making whether to operate or not. And this group came to the conclusion that DTI was valuable with amazing results, significant reduction of the complication rate. So our idea was to use a more specific way to image the tracts. As I mentioned, the classical DTI and even what you can calculate and model around DTI is not really showing you very specifically the tracts of interest. And we have learned this from our studies with brain tumors, where we are using navigated transcranial magnetic stimulation, which allows to identify, to map different groups of neurons representing different motor areas or muscle areas on the surface of the brain using this magnetic coil. And this allows us to map the cortical surface, and we have used this technique in a large number of brain tumor patients. And we have learned that anatomy alone is not really giving you the perfect picture and should not dictate your decision-making and approach, because the pathology within the eloquent area will shift function around. And with a pathology in an eloquent area, it becomes very difficult to really predict where the function is going to be in this individual patient. So if you're going for personalized, tailored surgical approaches, you need something else than only the anatomy. And this is what navigated transcranial magnetic stimulation can provide on the cortical surface in brain tumors. It's non-invasive. You use the magnetic field, and it allows you to give you a functional map. And this is how it works. You have the tumor in the motor area, in the precentral cortex here, in the hand knob area. It's clear that this is an eloquent area, and classically many surgeons would not have operated this, But using navigated transcranial magnetic stimulation, we can identify the leg area and the hand area. And many of these tumors became then operable that had been deemed inoperable in previous days. The adjunct now, the add-on or the asset is that these different points can be used as seeding or starting points for the DTI information. And therefore, we can reduce the DTI information to specific tracts that are resembling the leg, the arm, or even different muscle groups of the leg, of the arm, and also of the face. And this makes the information of the tracts then down to the brainstem way more specific than the classical DTI information. And here you can see how the DTI information, the classical, would look like on an axial image of the brainstem with a pathological lesion, with a cavernoma, which is, as Helmut and his group has shown, quite unspecific. It gives you nice colors, but certainly you can already say that this cannot be the ground truth. With the navigated TMS, we start with the seeding points for the leg, the arm, and the face. And from there, we have the specific tracts. And this looks much more, or way more specific. And you can identify the corticospinal tracts in the anterior part, and you can see the motor bulbar tracts a little bit posterior. And you can study now the distance to the lesion. You can study, let's stay with Michael, the triangle between the tracts, and you can appreciate how these tracts might have shifted, and you might change your approach depending on this information. So the idea was to evaluate TMS as an adjunct for brainstem cavernoma surgery. This is the information that we can collect. We have the motor strength of the patient. We have the resting motor threshold. This is the energy that is needed in order to elicit a motor response. If the tract is destroyed, or if the tract is impaired, you obviously need more energy, and the resting motor threshold will increase. The FA, the functional anisotropy threshold, reflects the integrity of the tract, or in visual information, the tract becomes less, the diameter becomes less if it's injured, and the FAT is changing. And then we have the distance to the corticospinal tract. And we know from the brain that, for example, a distance of less than 3 millimeters to the tract has a high risk of a post-operative motor deficit if the tumor is operated. And it's interesting to see how this will behave in a well-defined lesion instead of a diffuse infiltrating tumor, as in a cavernoma. So this is how it works. This is the scenario. We first performed the MR, then we performed the TMS the day before the surgery. We performed the motor mapping. We identify the seeding points. We then add the DTI information, and we determine the tracts. We get several tracts. We reduce it to 75% in order to be more specific of the FAT, and then we can perform the surgical planning and the risk stratification, or this was what we were aiming for, to see whether this is possible. So we started with 21 patients, and these are already published. And Anna Sunchik, one of our young faculty, is really the PI on this project. She's a super talented neurosurgeon, not only a good neurosurgeon, but also a computational neuroscience scientist. 21 patients, 15 were treated by surgery, and these are the 21 patients where we had the full mapping and the full imaging. 15 were operated. They were all symptomatic and had previous bleedings, and half was coming to the surface, and half was deep-seated lesions. Why were some of these cavernomas not operated? Because they were very close to the functional tracts, and already without the previous experience, the surgeon or the patient had deemed that this might be very risky, especially since the patient had been asymptomatic again. 2 out of the 6 were really deep in the brainstem. One patient was pregnant, and one patient decided against the advice to get the operation. So let's look at the 15 that were operated, in all different areas of the brainstem, and the approaches have been named. And how did the patients do postoperatively? So one patient had a new motor deficit, 3 patients had worsening of the preoperative motor deficit, and 2 patients had new cranial nerve deficits. 3 months follow-up, all the patients had some partial regression. The average MRS was 2.2 and a good outcome in 50%. And there were no new sensory deficits. 28 improved on modified ranking and 43 had a stable modified ranking. So this, and the motor outcome was that immediately post-operatively, 27 had a decline in motor grades of 1 or more. And by the follow-up at 3 months, 13% had a decline of the preoperative motor status, which compares favorably to studies out there that had just operated the cavernoma without the adjunct in the information or using classical DTI information. So just to give you an idea about some examples, this is a cavernoma in the medullary, centrally located, midline approach, medial suboccipital approach. And you can see in panel B, you can see the navigated TMS information with the corticospinal tract for the leg and the arm. Here are the bulbar tracts, and this is what the deterministic DTI information without the TMS mapping. And you can see the difference in the image quality and in the specificity of the information. This patient was operated and fully recovered without any deficits. And this could have been predicted because the distance of the cavernoma to the motor area has been less than 1 millimeter and more than 1 millimeter, so 2 millimeters. So there was a relevant distance. Different in this case. This is a case with a more anterolaterally located in the pons cavernoma on the left side. So in the TMS and in the planning software, right and left are shifted. So this is the left side. You can see the corticospinal tract for all 3 areas: head, leg, arm, and bulbar. However, on the left side, the corticospinal tract is interrupted, which correlates well with the preoperative hemiparesis of the patient. And here you can see the remnant of the corticospinal tract immediately next to the cavernoma. And this information here is from the DTI, again showing the increase in quality that you get with the TMS. And this is the postoperative picture following the retro-SIG approach. And again, you can see, and the patient has worsened in his motor to a grade 4 and has developed a new facial paresis, which simply reflects the low distance or the immediate localization between the cavernoma and the tracts. And to give you some idea about the measurements, so this patient had a resting motor threshold on the left side, which was normal. It was increased on the right side, reflecting the disturbance of the corticospinal tract. Also, the FAT was reduced, and the distance was less than 1 millimeter or 1 millimeter, and this is the clinical result of the patient. Case number 4, again, a rather big and diffuse anteriorly located lesion in the pons. Again, the differences in the imaging quality and the immediate association or the close association of the cavernoma with the tracts on the right side. And this patient was operated, and while the patient was operated, the monitoring showed a decline in the MEPs. This is why the lesion was incompletely resected, and it was also obviously difficult through a retro-SIG approach to get this whole lesion out. So more than half was left behind, and the patient fortunately had a good recovery clinically with this significant remnant in the brainstem. And finally, this was located more on the posterior aspect, and therefore was operated with a lateral supracerebellar approach. And again, you could see a good postoperative outcome. And the information that you can gain with a significant distance between the cavernoma and the relevant tracts for arm, leg, and the bulbar tracts. And you could predict that this patient would make a good outcome. So the resting motor threshold post-op could predict whether the patient would develop post-operative deficits. If the resting motor threshold was increased, so you needed more energy to elicit a motor response, then it was very likely that the patient would develop a worsening of his motor status preoperatively to postoperatively. The same is true for the size of the tracts. If the size of the tract was reduced or the tract was disturbed, then it was very likely that the patient already had a motor deficit preoperatively and would further worsen after the surgery. And you can see the correlation between the resting motor threshold and the intact and the tract, how the tract presented. And finally, we have extended our series meanwhile to brainstem tumors and to brainstem cavernomas. This is the series that has been fully mapped. And the outcome, again, has further slightly improved versus the primary series, because we have learned to identify our patients more specifically. We have optimized the approach. We have improved the intraoperative orientation. We know now exactly where the tracts have been shifted to, which in combination with the intraoperative monitoring improves our surveillance, and it improves also our dissection. We are very delicate on these areas where we know where the tracts are. We have all the information in the microscope and in the navigation, and we know exactly not only where the cavernoma is, but also where the tracts are. And we have learned that a distance of 1 millimeter of the tract to the cavernoma is predicting an unfavorable motor outcome. So patients that have a distance of more than 1 millimeter can be operated safely. So this has advanced to an indispensable routine technique. So concluding, we think that TMS adds to the information that we can get out of the anatomy and helps our preoperative planning and decision making. And we have evaluated its usefulness for detecting the corticospinal tract and the corticobulbar tracts. It's an objective visualization and shows out how the tracts have been shifted with the pathology in the brainstem, where all the function is packed very densely. And we can identify the somatotropy of the tracts on the brainstem level. We are now able to individually predict the risk for the individual patient based on the readouts we get from the TMS. And we have modified our surgical approaches individually, not only depending on the anatomy, but also on the function and on the localization and the shifting of the tracts. And this allows us a more aggressive surgery with a good resection, with a good extent of resection, and with a reduced risk of the preparation. So thank you again for having me, and I'm open for the discussions.
Peter, that was really terrific. Very well thought out, and of course makes perfect sense to add the physiology to the anatomy. And I'm sure we'll come back to some of those discussions later during questions. Two excellent complementary talks till now. And last but not least, Oliver Bozinov, take us to the last presentation.
Hello, Jacques. Hello, everybody. I hope you can hear me. I'm trying to share my screen.
Yes, we hear you very well. And
can you see it?
Yes.
Excellent. Well, thank you again for this invitation. It was a real treat when you invited me to talk about brainstem and share some thoughts about using techniques intraoperatively, which is my hobby, as I could say. And speaking after Michael and after Peter is not very easy, because they have already said so much, and I probably have to take out half my slides, but it makes my talk at least shorter. Anyway, I'll try to concentrate a little bit more on the intraoperative side and on intraoperative monitoring. And it was not in the title, but I will really try to see also, I want to talk a little bit about brainstem direct stimulation. So I have no disclosures. This is a slide that actually does not have to do much with intraoperative monitoring, but this very old but known paper shows we know it, but still it shows very nicely that brainstem hemorrhages are totally different when they are from cavernomas than if they are primary hemorrhage. And patients are doing usually very well with the GCS. Of course, they have some deficits and they see it, but we have to keep that in mind, that we do not over-treat brainstem hemorrhages, in my opinion, from cavernomas. The summaries of brainstem cavernomas that are very well known is that brainstem cavernomas do have an intent to bleed much more often, up to 5 times more often, or have a 50% chance in 5 years to bleed in the brainstem. We all know these older but still important series, also from the Spätzle group, an early series, but still. And the middle one is the Ducats, is from Helmut Bertalanffy, who was my teacher, and Paolo Ferroli from Milan, that we do have in average about 20 to 25% or 20 to 30%, depending on what area they are operated, of new deficits or permanent deficits. And MRS, of course, is very important. And as Peter mentioned, the motor tracks, and the more closer the cavernoma is to the tracks, and the higher the risk for a deficit, which of course has a big impact on the MRS. Other small series have also shown the same, that on long term, about 25% of brainstem cavernomas do have a worse outcome than before surgery. And this is very important, because if we think about a natural history of brainstem cavernoma, of course, there are some that are very bad, but there is almost an equipoise here that we treat when we treat brainstem cavernomas. So we have to be honest to the patient and talk about them for the risks and the benefits of such surgeries. And now treating those patients, and sorry to go back, now these still very high complication rates. We don't have those high complication rates on elective aneurysm surgery or something else, but this motivates us to find something to make this better, of course. Now I want to show this slide, and I'm very happy that the Barrow Institute has raised from 2 points to 7 now, and this very, very easy concept of 2 point, and that's it, how you take out a cavernoma, has evolved to a very complex method now, which was very interesting to see. But Bob Spätzle was also one of my teachers, not as long as you guys, but I spent only 6 months with him, but still I consider him very, very important in my career to understand the brainstem. Now there were 2 publications, one from the Spätzle group and one from the Oliveira group from Brazil, that was talking about safe entry zones, as also mentioned today in the first talk. And that was very interesting, because they came out in the same journal, and they showed safe entry zones, which half of them were the same ones, but there were also controversies. And I think actually Michael showed that in one slide too, that for the quadrigeminal plate, there is the suggestion to go in the midline, or there's suggestion to go above or below. So there's still controversy on this topic, and maybe we'll discuss that later in the cases that will come up. Now we looked at the literature as well with Yang, my fellow, and we found out 21 safe entry zones that were published. Some of them were only case reports, and you have seen some in a better 3D picture in the first image, but the evidence for these safe entry zones was actually very low, and most of the entry zones that had very good evidence, so a lot of cases, a high case number, or many sites that were using these entry zones, they were all in the midline. Now, as you see here, Helmut Bertalanffy, Peter mentioned him, a pioneer, or one of the really big guys for brainstem cavernomas, was many years my teacher. So I learned this really from him, how to think around and in the brainstem. And we did this study in Zurich about now 11 years ago, 12 years ago, where we looked for the variety of the facial nerve nuclei. And you can see, so on the left side, so we tried to map with direct stimulation the floor of the fourth ventricle. And we wanted to see the area where we have a stimulus for the facial nerve nuclei on both sides. So one patient has one color. Now in the publication, you can see in A, it's a little bit difficult. So one patient is one color. So for example, the blue patient, the facial nerve nucleus on the right side, a big normal one, a little bit lower than expected. And on the other side, on the left side, sorry, on the right side here, it's a lower, it's a much tinier nucleus. And each patient, you can see here the variety, and the A group is actually the group where there's no tumor in the pons. So those are basically healthy patients. So the tumor was far away from the facial nucleus. Now, B patients were patients where the tumor or the cavernoma was actually probably pushing the pons a little bit to the side. So meaning that the facial nerve is not infiltrated, but the facial nuclei could be displaced, but we don't know. And these patients, you see the variety, it goes all the way up or all the way down. So basically the anatomical safe entry zone, superior or inferior to the facial nuclei, cannot be taken just by assumption, just by anatomy. So by stimulation, we could show that the variety is totally different. And now the C group is the group where the facial or the cavernoma is really in the pons, exactly in the floor of the fourth ventricle, so clearly displacing the nucleus of the facial nerve. And you can see how big the area gets sometimes for the facial nucleus. So to use the safe entry zone of this in the fourth floor of the fourth ventricle, you need to stimulate the floor of the fourth ventricle directly to be sure where your facial nucleus is. And these findings really brought us to continue also the direct brainstem stimulation. Now, Bricolo, this is, I think, 40 years old, published already this in his book. And he said, you should really avoid the midline because he had a lot of complications with patients that have not just a motor palsy, but motor deficit, but really also deficits from the cranial nerves. And he actually published this, which is not in the anatomical book, that all these nuclei are connected to each other, like we know, as we know from the quadrigeminal plate and the nuclei. Now, this led actually in the next years, also in my clinic, to a favorable approach through the medial peduncle, as also mentioned in the first talk. So for the whole pons, using the medial peduncle is very advantageous because you are below, especially above the nuclei, especially for the trigeminal nerve and the other ones. And this one you really need to use through a infratentorial supracellular, so a very far skid approach. Now, if you look at the image below left, that means that the motor tracts, usually when the cavernoma is in the mid part of the pons, it really pushes the motor tracts to the front. You can see here a typical case. We were watching this case, we were not operating initially, and a couple of years later, you see a significant hemorrhage with deficits for the patient. We used this lateral skid approach, went perfectly fine. She had some mild hemiparesis, mostly through coordination, but she did very well and had no deficit in the next follow-up and no recurrence for the cavernoma in the follow-up. Now, however, if you use this approach to the peduncle, I always show this slide too, you must not disturb or destroy the superior cerebral peduncle or the inferior cerebellar peduncle, because they are a connection of the Guyon-Mollaret triangle. If you hurt that one, in either above or below, there's a high risk to have severe motor deficits for coordination, and these patients even get much worse in the weeks ahead. Those cases are published, and you can see in the picture below right, they do get this olivary degenerative disease, and they are basically impossible to rehabilitate, and they will walk terrible. So be careful in these cases. Now, in 2011, we also published our first experience on brainstem cavernomas and using motor-evoked potentials. And you can see, just as an example, on the left side, one case where we have the dura opening at about 10, 11 o'clock, and then slowly you have to go much higher with your amperes and with your threshold, and then basically you do not know when to stop. So when are the MEPs, when do you have to stimulate so much that actually the MEPs are in danger? And you see that the variety of elevation of MEP threshold is sometimes up to 100 milliampere higher in some cases. So MEP in general did help, but it was really depending on the technician who was on the table to tell you as a surgeon, is that real? Is it really a decline of the MEPs, or is that a technical problem basically? And Uli Suhre, also one of my teachers, but basically also a fellow that was learning a lot from Helmut Bertalanffy. He has now his own department and also doing giant research on cavernomas, really great stuff. And he just published this series of his cavernomas. They operated about six, I'm sorry, there's a problem with the button. They published about 60 brainstem cavernomas, and 30 of those they analyzed for the MEPs, and they could see that once they used the sitting position, so much air was going into pneumocephalus so that they actually had a problem to rely on the MEPs intraoperatively. So they saw also here a limitation. Now for us, we wanted to go a step ahead, so we didn't just want to use the MEPs. This was always our setting, MEPs and SCP, using the DTI, as shown in the second talk, that sometimes when the cavernoma is big, we do not see the DTI on the area where the cavernoma is, and of course we use the clinical outcome. But what we were trying now in the last years, and we did a study here, which I want to show, and was recently published in Neurosurgery, is a direct stimulation of lesions in the brainstem. So what was our idea is that when we have a movement of the facial, of the cortical spinal tracts through the cavernoma, and we do not see it preoperative in the DTI, but we assume where they are, we want to have direct stimulation of the brainstem and to see if we can basically show how far or how close we are to these tracts. Now, you can see in this illustration, we use different cases. Of course, we had cases where the cavernoma on the right was really pushing the cortical spinal tracts to the side. We also had cases where we had a tumor really compressing the whole brainstem and squeezing it to few 2-3 millimeters, so to map these cases. And we used also healthy patients with clear landmarks to know how far those are away from the cortical spinal tracts. We compared those to early postoperative DTI imaging and measured the distance to those, and of course used the clinical outcome with MRS and muscle strength. We stimulated those with 2 milliampere, 0.2 milliseconds, and 3 hertz, and we used a train of 5 at the end. We started with the 1 train in the beginning, but that was not very specific, and we changed to train of 5. Now, this is a typical case where we learned the most. Basically, one of the first ones, it's a giant metastasis squeezing the brainstem to about 3 millimeters. And you can see we were able to map the whole medulla after this case. With 2 milliampere, we had almost everywhere a stimulation. And with decreasing now to 1 milliampere, we could actually show the path of the cortical spinal tracts from the back of the medulla. You can see that we mapped it with a millimeter, and we checked this on the postoperative DTI imaging, as you can see here. So we looked at the distance, and we could say that when we were 2 milliampere, we were less than 4 millimeters away from the first cortical spinal tracts. And when we had 1 milliampere stimulation, we were less than 2 millimeters away from the cortical spinal tracts. This is another case with the same. So this patient was not squeezed, so we needed a little bit more. But when we went on the side of the medulla, where we're just really close, almost 1 millimeter away from the cortical spinal tracts, we were able to stimulate everything, stimulate the motor potentials with 0.8 milliampere. So the closer we got to the cortical spinal tracts, the lower we could go with 2 with a milliampere stimulation. Now, this is a very small table, but a very important table. So I will try to explain this. So yes, we were closer to 4 milliampere, and we had an intraoperative positive signal. So that's good. That was what we were looking for. Now, very important, we were not closer than 4 milliampere, but we did not have any point positive, which is important because we don't want false positive stimulation. On the other side, we had 570 points negative, and we were far away, more than 4 millimeters. So that's good too. But we also had some cases and some points where we were sure that we are closer than 4 millimeters, but we did not have a stimulus. So the specificity was 100%, but the sensitivity was unfortunately just 84.3. So we do not have 100% sureness here. Again, it was just published a couple of days ago in Neurosurgery. I want to show one negative case. It's not a Cavernoma case. It's a glioma case where we really needed this direct stimulation to take out this pilocytic astrocytoma. And we were taking out this tumor more than half, and we were sure we were very, very close to the cortical spinal tract, but we could not have in the pontine area a positive signal in this one case. Other cases that we used as these giant, I have to go a little bit quicker, this giant Cavernoma here, as you can see, so clearly less than 1 millimeter away from the cortical spinal tract, as Peter showed, but he was already very, very, his MRS was very high already. So it was almost a palliative situation for this patient, but he was the same after surgery. But in these surgeries, we do use intraoperative MRI. Early postoperative MRI for Cavernoma is not really helpful, but intraoperative MRI does help. But I show this case also because we were really very close to the superior cerebral peduncle, and that was almost too close. So we were actually lucky, and we didn't use the supracerebral infratentorial approach far enough. So when Dr. Spetzler says use it very far, he's very right. So in my summary, I can say that brainstem surgery will still remain eminence-driven. We will not have prospective randomized trials in studies in this way. The same is for monitoring. Evidence will also remain in the weaker level in the near future, but we continue to evolve our strategies, and we think that intraoperative electrophysiology is important, and we want to add brainstem mapping to guide you for the distance to the cortical spinal tracts. However, I always say the same. I favor the lateral localizations, and I guess we'll talk about this in the cases we will discuss. So thank you very much for your attention.
Thank you, Oliver. I mean, I couldn't have chosen 3 better speakers for this session. Of course, each one of you was spectacular and actually complemented each other's with really no overlap. And I can see from the audience questions and the number of people we have listening that this was terrific. Let us field some of the Q&A questions before we present the 2 cases. Question from Dr. Valdez: do you believe DTI would change the approach of an awake craniotomy? Like, I guess he was asking the question for a glioma on the motor cortex, but we can take this in general. Oliver, you want to answer this? Does DTI affect how change things if you're doing an awake crani? I mean, how much do you take it into consideration, or do you obviously fully believe what's happening in the awake craniotomy?
I couldn't say it will change. It's a very difficult question because it's so unspecific, you know. I don't know how much it will change, but for awake craniotomy, if it's motor related, I really do use the simulation section, and I really rely on that one mostly, to be honest.
Okay.
More than on DTI.
I would say it changes it has a significant impact on the planning and on the decision making. Number 1, you might change the approach. Number 2, you might change the decision to operate. And number 3, it also affects how you monitor and the decision whether to go awake or not. So at least the TMS-based DTI, both for language and for motor, has a significant impact in our practice.
Peter, why don't you stay on this for his other question? Also, just the concept of safe entry zone. He's asking really what obviously everybody talks about is, we call them safe. They're not really safe after monitoring because the cavernoma has displaced a fiber track. Just summarize for us or for the audience, what is this the concept of safe entry zone? How safe are they, and what's the limitation of them?
Asking me?
I'm asking you, yeah.
Okay, yeah. In my understanding, the safe entry zones really rely on physiological anatomy, on regular anatomy, and the safe entry zones might shift or might change depending on the space that the cavernoma is occupying, and any imaging information about the course of the tracts or about the localization of nuclei might be very beneficial in order to update your safe entry zone. And obviously, the mapping of the nuclei, if you come from posterior, is very important. And if you come from lateral or from posterior or anterolateral, then it's more about the tracts. And the one image that I've shown where we used the entry zone exactly between the bulbar tracts and the leg-arm tracts or the corticospinal tracts really gives helps to appreciate the value of this information.
Okay. A question to you specifically, Peter, from Dr. Alim Bayramov. What is the pros and cons of the navigated transcranial magnetic stimulation mapping in comparison to direct cortical stimulation?
The advantage is obviously that you have the information beforehand. Direct cortical stimulation is still the gold standard. At least supratentorial, there is a difference of a few millimeters between direct cortical stimulation and NTMS. However, you have the information before operation and you can plan accordingly and change your strategy. But we still rely on, or we still combine it with direct stimulation. So we don't leave it away. And the disadvantage is that you have the preoperative time that you have to invest. You need personnel and you need the machine, and the expertise.
Okay, Mike, question for you from Dr. Onya Udoshukwi. I'm not going to read the whole paragraph, but to maximize safety in general, it's a very general question. Do you favor, for beginners, a midline entry or a lateral entry to the brainstem?
Yeah, well, I think the short answer is if you have a choice and you can pick between a midline and a lateral, you're better off with the lateral. But the point of the taxonomy is that you really don't have a lot of choices in some of these. If you buy into the whole idea that every lesion has one perfect approach, then you just have to make sure you get to that perfect approach and you use that. Now, having said that, clearly, when you make a taxonomy, every lesion that you encounter in clinical practice isn't going to fall perfectly into these little nice, neat categories and descriptions. And so there is some variability. But I think generally speaking, my message is learn which of these different lesions is paired up with the different approaches, and that should be your guide. If it means going in the midline, that's fine. Just use your safe entry zones. And with regards to the safe entry zone question that was asked before, Oliver really published a great paper on this whole idea of are safe entry zones safe. And what was interesting in reading his paper was that all of these statements that safe entry zones are safe are primarily based on anatomy in cadavers. They're not based on clinical series. I think there were 5 or 6 in his paper that had a series of greater than, I think it was 25 patients that justify on clinical grounds that these are safe. So what we did, this is a paper that's going to be in the collection. We looked at our series, and we stratified patients that had lesions on the surface where you didn't go through a safe entry zone, and lesions that were beneath the surface where you had to go through normal brainstem tissue, and we compared them. And the hypothesis was that, yeah, the safe entry zone patients were going to do worse because you had to violate some normal tissue. And in fact, what we found was that they didn't do worse. And so I think I was surprised by that. And I think what it means is that these safe entry zones, it really does validate the concept. And a lot of that morbidity that all of us were showing in our talks has to do with just how close it is to the structures around it. It's not necessarily the tissue that you violate going through to make your initial contact. It's all of the other things that are touching the lesion on the periphery. That morbidity comes from that more than it does going through that safe entry zone.
Great, thanks. Question to Peter again from Dr. Shihao Kao. You reported a partially resected CavMal due to change in evoked potential intra-op. Can pre-op DTI help predict that? I guess we probably partially answered that question earlier, Peter. Would you resect part of the CavMal if some parts of the CavMal are too close to a functional tract?
Yeah, what we know is that you can be sure that you will have a motor deficit if the distance to the corticospinal tract is 1 millimeter or less. So in this case, we either decide not to operate or try to remove everything with improved neuromonitoring, but usually something might be left behind. You can discuss whether this makes sense. In most cases, we would say that we would rather not operate if the patient is asymptomatic, if it's too close.
Okay.
But I mean, the incomplete resection of this CavMal was for different reasons. It was technically, I think, not perfect, and we had the issue with the loss of the MEPs.
Yeah, that's an interesting point, though, worthy of some comment. You know, it's pretty rare that you take out one of these and you don't have some change in your monitored potentials. And I've come to believe that you almost have to ignore the neurophysiology intraoperatively, because you're there to take this thing out and you're going to get change. It usually comes at the end when you're right through the meat of the malformation, you're right on the skin, right against the tracts that you're worried about or you're monitoring. And if you allow yourself to be deterred at the home stretch, then you've essentially failed in your mission. And so I've become a little bit callous to the neuromonitoring, and I would almost go so far as to say that the intraoperative monitoring really doesn't add anything.
Well, Mike, then stay on that thought, and why don't you answer Onya Udoshuku, who's asking, well, we don't have intra-op monitoring and mapping available in our practice. Apart from good anatomical knowledge of the taxonomy, as discussed, are there any other strategies you would advise to keep surgery safe in the absence of neuromonitoring and mapping?
Yeah, so
I assume you'll be reluctant to say that mapping, is not useful at the very least.
Yeah, no, you can't not monitor or map, right, because it's become standard of care. I think it's a medical legal issue if you decide not to do that. So I'm not saying that we should ignore or not provide that service as part of the case adjunct. But I think that the real answer in my mind isn't necessarily that you get the mapping to do these cases. It's that when you're in surgery for these, you've got to have the right technique for resection. And I've always believed that the reason we get away with brainstem cavernous malformation resection is because we work inside out. We work inside the lesion. We do most of our resecting within the pathology, and we only get close to the normal physiologic tissue at the very end when we're through all of that pathologic tissue and we're just at the very edge.
Great. I think we can go to cases. Eva Wu, our PG4, will present a case to the panelists, and after that, Matthew, the fellow, will. You're muted, Eva? We can't hear you, even though you're unmuted. Is there something wrong with the microphone or your laptop, maybe? Huh. You know what? Let me, Matt, are you there?
Yes, I'm available.
Oh, by the way, is actually Mike Ivan? Are you? I don't know if Mike was my partner. If Mike had any comments or about anything going on, Mike.
Yeah, thanks so much. I mean, fantastic presentations by all three. Just two quick questions. One was for Peter and Oliver, just with the use of tractography in the brainstem. You know, there's also this concern that when you have edema in the preoperative area, when you have an when you have these patients who present with rupture, are you concerned about the authenticity of the DTI during that initial edema period? Are you waiting a certain period of time to kind of do the TMS, get the tractography in all patients, or are you correcting for that with some kind of edema correction?
No, I mean, edema impairs your DTI, and whether you use the original DTI data or whether you use the TMS, if there is edema, then the DTI will be impaired, the tract will be impaired, and the FAT will be impaired. And this is, but then they are very close to the brainstem, to the cavernoma usually, and this is then just reflecting the vicinity and the risk of injuring the corticospinal tract. But absolutely correct, edema impairs the DTI, but every patient meanwhile gets DTI before we go to surgery.
Yeah, it's kind of a little bit like the monitoring. You know, we learned, and our group has shown that the DTI pre-op is sometimes devastating and not helping at all. So I think Peter has a very good solution for that, and I really learned much about this. But again, we will still do it, and most of the times we are disappointed.
And then one more question for Professor Lawton. So, you know, being that your case volume of these is so large, it also comes with the fact that you probably have recurrences. And so I want to know if the taxonomy that you're using and the approaches on the second attempts at these, is that changed? Do you treat them like a new experience, or do you take into account the old approach, and how do you kind of alter that, make that change as you make those decisions?
Yeah, that's a great question. We looked at that, and that's another paper that's in process. For the majority of those cases, when they recurred, we went back in the same prior approach, because you've got a track, you've already made a brainstem entry, and so going through that scar tissue was actually helpful. But there were cases, particularly recurrences that were referred, done at other places where they differ in their approach philosophy, and in those cases, you know, we for example disagreed with the approach, and we chose a different one. A great example is, you know, we saw a guy from Mexico not too long ago who had an approach through the fourth ventricle that took out his facial nerve and his sixth nerve, and had new deficits and recurrent lesion, and the part that remained was the part lateral, the hardest to see, and so going through the MCP for that was a much better choice, because it's a new corridor. It's the best, most direct shot to the residual, and so we changed. But I think those cases were the minority, and frankly, with regard to residual, I think residuals are hard. If you leave something behind, there's a very good likelihood that they're going to bleed again. So I think you know, I'm pretty dogged about making sure I've gotten every last bit, that if I see something on the post-op MRI that I don't like, that I'm certain is residual, I'll go back and I'll get it, because those things bleed again. And then, you know, to drag a patient through rehabilitation, recovery, the good feeling like they've gotten over their disease, only to have it recur and have them have to go through it again, that's just a real devastating cycle. So I think it's important we be perfectionistic.
On this thought, Mike, early on in my practice, I was so careful about not touching even a small vein leading to a DVA. But then I had 2 recurrences, and the common thread, it's only 2 at the time, the common thread was that I had left a vein, and then when I went back in, I took the vein, haven't recurred. What are your thoughts about being too careful about venous? I mean, there's a difference in my mind between the draining vein of a cavernoma that then dumps into a main large DVA. We're not going to sacrifice a large DVA, but I now routinely actually take the vein that, you know, that on the cavernoma.
Yeah, so it's another great point. I view the caput medusa as the fingers and the arm, and I think it's okay to take the fingers. The fingers are what touch the lesion, and if you're too reluctant to work around the fingers and maybe take a finger or 2, then you leave residual, and I don't think that's a good trade-off. I think you're better off getting every last bit and sacrificing a few fingers as long as you say, you preserve the arm.
Yeah, I like that analogy. That's great. Okay, Matt, why don't you go ahead? I'm not sure if Eva is fixing.
Sure, yeah, I can
issues.
go ahead and share my screen. Okay, you can see my screen?
Yes.
Yeah, so I'll be presenting one case that Dr. Morcos performed about a year ago. So 15-year-old boy who was previously healthy and developed, unfortunately, acute onset ataxia, diplopia, dysarthria, and facial paresthesia. And he was residing at another country at the time, and they performed an MRI, which demonstrated a hemorrhagic pontine cavernoma. And he was initially treated medically with Decadron, and he still had residual bilateral horizontal gaze deficit and ataxia when he came to our attention. So on exam, in addition to the complete bilateral lateral horizontal gaze deficit, he surprisingly had symmetric face, but he also had dysmetria and unsteady gait. So this was the initial MRI that was performed at his home country, where you can see the cavernoma and the hemorrhage. And when he came to us about 2.5 weeks after, we immediately performed a second MRI, which already demonstrated rehemorrhage. And so at this point, he was almost unable to walk. He had also difficulty speaking as well. And we felt that he was an appropriate surgical candidate. And just before the surgery, we performed another MRI. But before that, we performed a DTI, which you can see the brainstem fibers were actually split perfectly at the midline and splayed bilaterally. And so this was the pre-op MRI, which was performed, only 1 week after the second MRI, and it showed further rehemorrhage, where the hematoma posteriorly or dorsally was really tenting up the floor of the fourth ventricle and coming really close to the surface.
So Matt, you want to ask them now how they would
manage?
So we have more slides to show before.
No, I think I was going to propose some of the thoughts that we had at the time, but maybe perhaps.
Yeah, let's ask them now, and then you can tell them what your analysis says. Oliver, what do we do with this guy?
Yeah, that's a very tough one, of course. Of course, you don't choose easy ones.
Yeah, well, and he's a wonderful tennis player, the patient. Actually, it's almost, a teenage champion of tennis. And they showed me videos, of course, of him playing tennis, and then he can barely walk. His face was normal, and obviously that's important. What would you do?
Okay, I'll make it quick. I would stay with my lateral on the right side, skid approach, far, and then brachium pontis, medial brachium pontis, go deep. I would not go through the midline of the floor of the fourth ventricle.
Okay, Peter.
I would also come from lateral, but I would like to see, I mean, I'm confused because you said that the tracts are displaced laterally because there is no tract that is going from anterior to posterior through. So I would guess that you have one anterior and one posterior, and I would try to go in between from lateral. I would even consider, I mean, we would have to see other images like a coronal, but is it maybe possible to go through a posterior Cavase approach or something like this?
Too
You
low.
don't think it's too low, Peter?
Yeah, it could be too low. I mean, it's maybe be below 7-8, but yeah.
Mike?
Yeah, it's too low. It's too low. I can see it. But this would be high enough. So, I mean, 2/3 are above, but not the whole one.
Mike, where does this fit in your taxonomy and how you'd approach it?
Yeah, so one of the issues with taxonomy is that when they're so big, then they touch multiple distributions, and it becomes a little challenging to decide which is the dominant one. And I think in this case, what you can glean from this is that it's really a central pontine lesion that touches multiple surfaces. It touches that supraolivary surface that we talked about, the underbelly of the pons. It touches the lateral pontine surface on both sides, so it's a middle peduncular as well. And then it pops out in the front in the basilar territory to the left, so that it really, I think, spans probably 4 different zones. And the interesting thing about lesions that are that big is that you actually then have multiple choices. You know, there isn't just one choice that fits one lesion. And so then it becomes actually a little bit more difficult to then decide on the right approach. And that becomes a real clinical bedside decision. And, you know, I'm really moved by the fact that you say his facial function is fine. As much as that thing herniates into the 4th ventricle, I think if you went in from the back, you'd be banging up against the facial nerve so much that you'd take his facial function away from him. And so I would probably do a lateral approach. I would not do a skit. I think it's too low for a skit, but I would do a extended retrosigmoid and a transmiddle cerebellar peduncle approach. And I think it was skewed a little more to the left.
Matt, scroll through the axial ones so Mike can, yeah.
Well, maybe not, maybe a little bit more to the right. But yeah, the MCP is the workhorse. When you go through that MCP, it gives you a lot of flexibility to go superior and inferior. Also gives you flexibility to go anterior and posterior. And so I think for as big as this is, I think the MCP would get the job done really nicely.
Mike, when you go from retrosig, do you think you can go all the way back to the 4th ventricle again?
I know you can. You have to use the extended retrosig, though. You can't just do a traditional retrosig. It means splitting the petrosal fissure, opening up that interlobular triangle, and really getting an entry into the peduncle as lateral as possible, and that allows you to angle back.
I mean, the problem with these big ones is that you would like to have an approach that is really shooting or directed along the longest axis of the pathology, which brings me to Oliver's question. Yeah, you often have to go around angles, then look behind or look to the side.
Yeah, very true, very true. And it's those angles that leave or create corners and blind spots, and so it does make it challenging. But that said, you know, this malformation has a lot of blood in it. And when you get inside those blood-filled pockets and evacuate, it does create visibility that you don't normally have. And so, you know, once you start to pull lesion out, you're going to have an enormous resection cavity to look around.
You said that you are not doing the pre-sigmoid approach. So in this case, you wouldn't even consider the pre-sigmoid approach or even combined with an anterior petrosal together?
I think I wouldn't. No, I think the Kawase approach is very, very narrow and very limited, and you need a lot of mobility to work around those different corners that we were just talking about.
But you could combine it with a pre-sigmoid, which gives you more room than a extended retrosig.
Yeah, you could. I mean, if you wanted to do that, but that's an enormous approach that I think is overkill.
All right, wonderful discussion. Let me see. Matt, why don't you carry on with your slides?
Of course. So, all the speakers brought up very good points. There were two options, obviously, dividing between perhaps a midline approach versus a lateral approach. And midline approach in this case will be something where you go through a televelar approach, midline, and given the intact pre-op facial nerve function, the idea would be that you would potentially be able to actually directly stimulate on the surface of the fourth floor and be able to identify the facial colliculi, perhaps bilaterally, and then make a small line approach. For a lateral approach, I definitely agree with all the speakers that it seems to come to the surface both on the right and on the left side, but really just kind of carefully scrolling through all the sections laterally where it comes closest to the surface will be on the left side at the pontomedullary junction, where if you were to perform a far lateral approach that would include an extended retrosig with it, perhaps you can find that safer entry zone, so to speak. And again, not to belabor the point, but in this case, a median sulcus approach, but through kind of already splayed fibers where there may no longer be as much of the functioning fibers left. And then through a lateral approach, either a supraolivary approach that Dr. Lawton talked about, or somewhere over here in this illustration. But in the end, I think Dr. Morkos decided to perform a midline approach through a bilateral televelar approach with the standard cranial nerve and SSCP and MMP monitoring. And he did directly stimulate the facial nuclei bilaterally at very low thresholds, and was able to get into the hematoma, just like Dr. Lawton predicted. Kind of a cavernous cavity had appeared, and was able to, piecemeal gently pull out the different pieces until he was quite anterior already in the pons. And so this was the immediate post-op MRI. And patient was able to be extubated immediately after surgery. And the immediate post-op exam, he had a little bit of facial weakness on the left side, House-Brackman 2. He still had the horizontal gaze palsy. After about a week-long hospital stay, he went to rehab, during which his ataxia, dysmetria, and the right lateral gaze improved. And this was the 6-month post-op MRI with the DTI.
Nice.
And then the 1-year post-op MRI. And we actually recently just saw him in clinic, and with his and his parents' permission, we wanted to show you all the exam.
Real fast. Okay, left hand. Wow, this is pretty good, pretty accurate. Okay, now let's zoom in on his face so we can, that's the anisotropy of the right eye. To the left, yeah, no horizontal gaze of the left eye.
Could you do that first one more time?
Yeah. Okay, look up, look down. Okay, show me your teeth. Good, close your eyes real tight. Good, excellent, that's fine. You can hear well, yeah, on both sides.
Yeah.
Do you feel me normal in the face?
Yes.
Okay, any numbness in the body?
No.
No?
No.
Okay. Go ahead, come walk to me. Very good, and have a seat.
That's it.
This is really more a testament to incredible ability to recover, isn't it? I mean, it's and he went back to playing tennis. The eyes did not really, the gaze did not really improve, and we're trying to help him how else to get the gaze. Now, the reason for choosing the approach I did is just the long axis of the cavernoma. I hate the fourth ventricular entry, but I felt I had really no choice given the direction in which the hematoma was growing. Any comments from the panelists? Or?
Doc, was the was the layer of tissue on the floor, was it violated by the lesion?
Yes, it was. It was. Exactly, which made it, that's why it made it easier.
Yeah, that's huge. When the lesion pushes itself through and becomes exophytic in the fourth, it's a highway.
That's your highway, and it happens to be the long axis this way. I really struggled pre-op trying to figure out what's the best approach for him, particularly as it kept, like, you know, a malignant cavernoma kept bleeding and growing 3 times in a row.
Yeah, I've gotten more conservative with my use of the transventricular approach because of the surgically induced INOs are terrible, and you know, yeah, and you never wanted to create that. But you know, I think this was a good choice for that. I can see how if it had pushed through and it was exophytic, it really does give you the best shot.
Yeah, yeah. I have Eva next to me who was having laptop issues, so she's going to show you the second and last case. Eva, here you go. Shall we do share screen?
Yeah.
This one, yeah. Okay.
I think you just have to pull it to the
What do I
over
do?
so you can
Oh.
share it. Yeah.
There we go.
And then
Yeah,
this.
here.
Mhm.
Okay. We're still, yeah, go
Yeah.
ahead.
Okay, so yeah, this is the last case. It's a 63-year-old female who had a sudden onset left hemibody numbness and facial droop and hypoacusis in 2017. And then her symptoms got better. Then about 2 years later, she again had sudden onset diplopia, which resolved. And then 2 years after that, she had left hemibody numbness, hemiparesis, and then conjugate gaze center palsy on the right. Otherwise, she had no other relevant past medical history. And so here's her pre-op imaging. You can see she's ambulating with a cane and limping on the left. And so here's her imaging, 2017, 2019, and 2021 respectively in the left, middle, and the right. And so you can see that the cavernomas bled 3 times, and it's grown and growing more towards the fourth ventricle now. And so the next you'll see the sagittal. And so the cavernoma is pretty much going from the caudal to the rostral extent of the pons. And so we just wanted to ask the panelists, you know, how they would manage this patient, 63-year-old with a pontine cavernoma that bled and grew, you know, 3 times. And so here's her exam, and here are the key images below for the panelists.
Mike, you want to take a first stab at this?
Yeah, sure. Unlike the prior one, you can see very clearly on the T1s that there is a layer that covers the lesion in the fourth ventricle. So it's not going to be amenable to that, even though that T2 on this slide here, it looks like it's bulging in. I think you're going to be misled by the T2, and the T1 probably is the real truth. And even what we found is that the T1 is, it still overreads the amount of surface presentation. So I think for this one, if you look at that lateral presentation to the right in the MCP, it really nicely presents to that spot. So I would do a right extended retrosigmoid trans MCP, and I think that would be pretty straightforward for him.
Oliver?
Yeah, lateral mesophytic sulcus, I think, is would be one of my favorite too in this case.
Peter?
Yeah.
You joined the group.
Lateral. I'm just wondering whether you would get to a supracerebellar infratentorial, but I guess it's too low for that. Yeah, retrosig maybe.
Yeah, so exactly like what the panelists all said, we decided on doing the approach through the middle cerebellar peduncle and went through this, we split the petrosal fissure. And just for the audience, here are the 3 like lateral, you know, entry zones to the brainstem that you could do. And then here are just the dorsal ones that, you know, we won't go into just for time's sake. And so we positioned the patient lateral, did a C-shaped retroauricular incision. And so here is just a figure that Dr. Morkos's old fellow from 2 years ago, Nick Kahn, he made. And so he's actually watching this Symposium right now, but this just shows the expanded versus the standard retrosigmoid. And so it just shows if you take more bone over the sigmoid, you can see more medially compared to the standard retrosig. And so for this video, we get CSF from the foramen magnum, and we start to dissect arachnoid from the lower cranial nerves, and then start working superiorly towards 7 and 8, which you see right here. And so then after this, we start dissecting and splitting and widening the horizontal cerebellar fissure. And so you'll see later on that we're actually working between the superior and inferior semilunar nodules, like what Dr. Lawton was talking about earlier. And so here's just a roten schematic of what the two lobules that we're working between. And so after the horizontal cerebellar fissure is split, you can see the middle cerebellar peduncle here. And then we use intraop navigation just to confirm we're at the correct location. And so there's a little bit of brain tissue that we had to traverse to get to the cavernoma. But once we get to the cavernoma, we start using a combination of sharp dissection to work in the gliotic plane and remove the cavernoma piecemeal. And so I'll just fast forward through a little bit of this. And so yeah, here we're removing the cavernoma. We removed it in about 2 pieces. And then afterwards, we just inspect the cavity to make sure, we had all residual, there was no residual, and the monitoring never dropped during the case or anything.
Yeah, Mike is absolutely right. That extended retrosigmoid is really good in entering the MCP and gives you that angle. And I think you have the post-op, and there's a nice tract, of course, that shows you. Go ahead. Sorry. Go ahead.
Oh yeah. There's a nice tract here, like what Dr. Morkos was saying, that shows you where we went through.
That T2 is beautiful. Like, show that T2 if you can't.
You mean pre-op? Oh, this one, yeah.
Yeah. Oliver was asking, can you get far enough back with the trans MCP? And that line shows you perfectly. You're literally on a course to the front part of the lateral ventricle, the floor, essentially, when you enter that far lateral.
Can you lift up your arms, both of them?
Yeah, that's okay. She's
excellent.
good.
Opening,
yeah, she did very
hands.
well. As nothing, everything moves and all that. Okay. That's it, isn't it, Eva? Okay, I'll stop sharing.
But Jacques.
Yes, sir.
Just maybe a small comment. And I always advocate a lot going from above, but this lesion was really close to the superior peduncle, and coming from below, from retrosig, probably you saved it, because I guess she was doing also good after a couple of months later, right?
She did very well, yeah, immediately post-op.
So
yeah.
I think coming from below, from retrosig, was really the key here, not coming from above and going down, because I was very concerned for the superior peduncle here.
Right.
That's a great point. I can tell you that that paper you mentioned and that Mulleray's triangle problem, in my experience, I've had it twice, and it's been in both cases going low with the skit, taking a lateral skit and trying to drop further low, and it gets you into the FCP, which is dangerous, and those patients are devastated, as you noted. Jacques, I wanted to ask you, the trans MCP is a wonderful approach, and obviously you recognize that, but I've always viewed it as a three-handed approach, because you go through enough tissue that you need almost one hand for the bipolars to open up the tissue tunnel. You need a suction in there to keep everything dry, and then you need your third hand to do all the dissection work. And I think what makes that approach hard is that obviously we only have two hands. So I'm just curious how you manage that.
Well, you saw I put the retractor. Is that what you mean? I mean, I just held the superior semilunar lobule with the retractor, which you and I don't use the retractor much, but this was useful to free up my hand.
Yeah, but the part that closes on you is actually the MCP. Like if you have to go
Oh,
through.
I see what you mean. Oh,
When you go
What-
through 2 centimeters of tissue and you've got that little
Right.
tunnel, it wants to close on you.
oh, I use cotton balls. I mean, I keep them open with not the ones with the string. I actually cheat and I cut cotton, you know, like when you do the interhemispheric approach or something, you know, keeping that's what I do. But I see what you mean. Yeah. Well, I think our European friends are champs for.
I have a question.
Oh, I thought
All
you
of
wanted
you.
to go to bed.
No. I have a question to all
Okay.
of you. Sometimes in these brainstem cavernomas, when you have taken out the clot and the cavernoma, then you have a very sclerotic tissue. Are you taking that out or are you leaving it in? And sometimes you find some cavernoma still in the sclerotic tissue. It's very hard. It's like a scar.
Yeah. Well, scar is usually gliosis. I challenge it and I poke it and I see if I can convince myself I see mulberry-like stuff or bloody stuff. Otherwise, I stop. And I've used, you know, the endoscope a number of times to look around, you know, around the corners and stuff like that.
Because the MRI post-op looks perfect if you take it out and the function is preserved, but I'm not sure whether I was just lucky. How is it with you, Michael? You leave that sclerotic scar-like tissue inside or you take it out?
Yeah, I agree exactly with what Jacques said and how he said it. I think you can be fooled that there can sometimes be scar that's disguising some residual. So you do have to challenge it, but you also don't want to get beyond that little thin shell and start getting into normal tracts and normal tissue.
Anything, any comments, anybody on the panel, the audience? I think we've answered all the questions. If not, this is a terrific session for the ages. Of course, it's recorded. Anybody can later view it, see how much younger we all were 2 years ago compared to today. It's great to see you, my good friends. Thank you very much for outstanding talks, and to Matt and Eva and my colleague Mike, and I don't know if Bobby Stark is there. Till we meet again. Bye, everybody.
Bye-bye.
All right, thank you.